I'd like to thank the United States Hispanic Leadership Institute and Dr. Tony Novello for inviting me to make this presentation at the 2021 National Conference. As you can see from this title slide, I will be talking about the challenges and opportunities that we are faced with in 2021 with regard to COVID-19. If one looks at this slide, one is impressed with the fact that we are dealing with the most extraordinary pandemic of a respiratory illness in 102 years since the iconic pandemic flu of 1918. Thus far, since its first recognition in December 2019, January 2020, there have now been 108 million cases and over 2.3 million deaths globally. The United States, unfortunately, is the most hard hit of any country in the world, with over 27 million cases, and as of just a few days ago, over 470,000 deaths. If one looks at the daily cases and hospitalizations and deaths, you see the sharp peak towards the end of 2020, the beginning of 2021 that we experienced. Fortunately, as you can see in each of these components of this slide, that we seem to have stabilized and plateaued. However, we must keep our vigilance up as there is now the appearance of variants or mutations of the virus, which might well lead again to another surge. Hopefully this will not occur, and that the vaccines that I'll mention in a moment will block any possibility of having yet again another siege. One of the most important and remarkable aspects of this outbreak is the extraordinary racial and ethnic disparity, where African Americans, Latinos, and other minorities suffer disproportionately, both in the incidence of getting infected and once infected because of underlying medical comorbidities, the outcome tends to be more serious with greater hospitalizations and deaths among minority populations. This slide is a good example of just that phenomenon. Note in the red bar, 136 deaths per 100,000 population among Hispanic or Latinos compared to whites, which is 111. This outbreak is unique in so many ways. Anywhere from a third to 40% of people who are infected have no symptoms. And importantly, more than 50% of all the transmissions from an infected to an uninfected person comes from a person who has no symptoms. Either they are pre-symptomatic and have not become symptomatic yet, or they will never become symptomatic, as shown on this slide, which makes it very difficult to do the classic type of identification, isolation, and contact tracing. The fundamental principles that we have been preaching about continually to prevent the acquisition and transmission of SARS-CoV-2 is the universal wearing of masks, the maintaining of physical distances, usually at least 6 feet, the avoidance of crowds and congregate settings, particularly indoors, and to do functions to the extent possible, weather permitting, more frequently outdoors versus indoors. And finally, the frequent washing of hands. For those individuals who do develop symptoms, remember, I told you that anywhere from a third to 40% of individuals never develop any symptoms with this infection. But for those who do, about 80% of them, the symptoms are mild to moderate. But about 20% or so have severe or critical enough symptomatology that leads to case fatality rates ranging from a few percent to as high as 20% in those individuals who are hospitalized and requiring mechanical ventilation. The manifestations of severe COVID are dominated by the acute respiratory distress syndrome. But the more we have learned about the clinical course of this disease, the more we see other organ systems involved, including cardiac dysfunction, acute kidney injury, neurological disorders, as well as unusual situations like a hypercoagulable state manifested by microthrombi in small vessels and thromboembolic phenomenon that can lead to acute strokes, even in otherwise apparently healthy individuals. There's an unusual syndrome in children called multisystem inflammatory syndrome, which is very reminiscent of Kawasaki syndrome. The people who are at increased risk for severe COVID are older individuals, namely those 65, 70, 75 and older, as well as people of any age with certain underlying medical conditions. We've noticed, and we're studying this intensively, that variable proportions of people, when they recover virologically from SARS-CoV-2, they have persistence of a constellation of symptoms which seems to be consistent among the group of individuals. And that is extreme fatigue, muscle ache, temperature dysregulation, and what some have referred to as brain fog, or an inability to focus or concentrate. With regard to countermeasures, a number of therapeutics have been tested, some in randomized placebo-controlled trials, and have shown variable degrees of efficacy. For example, remdesivir has been approved by the FDA. It is a direct antiviral agent. A number of monoclonal antibodies, predominantly from the companies Lilly and Regeneron, have been given emergency use authorization, as have convalescent plasma. A very important randomized placebo-controlled trial indicated that the commonly used glucocorticoid, dexamethasone, when given to individuals hospitalized on ventilators or requiring high flow oxygen, has a significant positive impact on diminishing the mortality at 28 days. And finally, the great success story of this pandemic has been vaccines, to develop in an unprecedented short period of time both safe and highly efficacious vaccines. This slide shows the vaccines that the US government has played a role in either developing and or facilitating the clinical testing of vaccines of 3 separate platforms: nucleic acid, particularly messenger RNA, with Moderna and Pfizer-BioNTech, adenovirus vectors, and recombinant proteins. We have been beset with an interesting challenge, that there have been the emergence of variants of some concern in different countries, starting off, for example, with one in the United Kingdom, the B117, which as a virus is transmitted much more efficiently from human to human, and in some studies was shown to be more virulent. This variant is currently in the United States in well over 35 states. Fortunately, the vaccines that we have available work well against this. Somewhat more problematic is a variant in South Africa, which in fact is eluding the protection of certain monoclonal antibodies, as well as diminishing the capability of vaccines to induce protection. Although against severe disease, the vaccines still seem to work. We will have to address these variants if they begin to replace the standard virus that we now have circulating. I want to say a word about herd immunity in the context of vaccines. It will take, I would imagine, and this is a pure estimate, but it's based on some extrapolation from what we know about measles, that if 70 to 85% of the people in this country get vaccinated, you will have an umbrella or a blanket, as we say, of herd immunity over the entire population, which would lead to a dramatically diminution in the viral persistence in the community. The challenges to achieving herd immunity are whether or not individuals want to get vaccinated. And that's the reason why we're extending ourselves to try and convince those who have vaccine hesitancy or some skepticism about getting vaccinated of why it's so important for themselves, their families, and their communities to get vaccinated when vaccine becomes available. I want to close with this final slide. We have been experienced over the last now 18 years, 3 coronavirus pandemics: the original SARS, MERS of the Middle East Respiratory Syndrome, and now COVID-19. So a considerable effort is being put into developing countermeasures, particularly vaccines, that would protect us against the current and all potential pandemics associated with coronaviruses. Thank you.
Hispanics come from a collective culture where group activity is dominant, responsibility is shared, and accountability is collective. Harmony and cooperation in the group is emphasized more than individual function and responsibility. Hispanics come from 21 different countries, including Puerto Rico. They are from different races and do not have a uniform social class status. They range from upward mobility, English language dominance, to inner city marginalization. COVID is not in the Hispanic community because of behavior, but because of systems that have kept us in substandard housing, with substandard conditions, in violent neighborhoods, excluded from labor laws, with inferior education for our children, limited economic benefits, no political coverage, and prejudice in the healthcare system. Hispanics, we are 18.3% of the US population, 60.6 million. 61% are Mexican, 9.5% are Puerto Ricans, 3.9% are Cubans, 9.5% are Central Americans, and 6.3% are South Americans. Hispanics consider themselves white alone, 39%. Some other race, 15%. 2 or more races, 2%, and black alone, 1%. 40 million use Spanish at home, 18 million are monolingual, 19% only speak Spanish at home. The older generation, 83% use Spanish at home as well. 23% use English at home, and 55% have limited English proficiency. But Hispanics, in spite of being 18.3% of the United States population, they are 33% of COVID cases, 3 times more likely to get infected, 2 times more likely to die from COVID-19. 1 out of every COVID deaths are Latinos. Children of color are 5 to 8 times higher rate of infection. We have 4 times higher hospitalizations. Between the ages of 40 and 59 years, Hispanics are infected 5 times higher than the rate of whites. 45% of Hispanics under the age of 21 have died of COVID-19. 73% of those that died at home from COVID before getting to the hospital were Hispanics. Why, would you ask, COVID affects Latinos? And I will tell you, discrimination, chronic toxic stress. Hispanics choose between staying at home and being safe or going to work and getting sick. We also have underlying health conditions. We have lack of health insurance. We have no access to testing, and the fear of deportation is there. We have lack of transportation, it's always crowded. We have no ability to take time off from work. We have a cultural barrier, we have a language barrier, and we absolutely have a provider bias in this country. And among all, we have education. We have lack of bilingual information for prevention in the lower high school completion. But on top of that, we have essential occupations. We expose ourselves to the virus every time we clock into work. We also have multi-generational housing. With isolation and social distancing, it's impossible. One gets sick and everyone under one's roof gets sick as well. 1/3 in every household is experiencing coronavirus symptoms as we speak. We also have institutional inequalities, greater degree of evictions, and on top of that, we have social determinants of health. As you can see, Hispanics bear a disproportionate share of infections. They are positive for the coronavirus at rates higher than would be expected for their share of the population. In all but one of 44 jurisdictions that report Hispanic data, 42 states and District of Columbia, the rates are 2 times higher in 30 states and 4 times higher in 8 states. We absolutely suffer from lack of health insurance, no employer-sponsored insurance, no testing, therefore we are undercounted, no time off from work, no paid sick leave, no flexible work schedules, no retirement account, only 30% participate, no reserves, they borrow, they use savings, or they sell their assets. They have no bilingual information for prevention, and in addition, Hispanics are 52% able to keep their jobs, but 40% took a pay cut. 29% lost their jobs, the highest income with those that make less than $25,000. 24% of them have low wages. 41% of them have fear of COVID, and therefore they don't go to the emergency rooms even when the need is very acute. 45% of them have less than $1,000 or less in savings for emergencies. 41% cannot pay the rent, and 20% has less than $100 in their savings. So as you can see, our life is not easy. We work in 15 industries in which they are 1/4 of the labor force, but 3/4 of the COVID cases. Hispanics are overrepresented in frontline jobs where they are exposed to more risks. Manufacturing, wholesale, construction, housekeeping, transportation, sanitation, landscaping, agriculture, animal slaughtering and processing plants, frontline medical personnel, grocery stores, stocking store, delivery of meals, food production lines, hospitality and leisure industries, home health aides, and child care workers. Really, 58% of the workplace outbreaks of COVID-19 cases were in 3 sectors: manufacturing, wholesale trade, and construction. And in addition, Latinos went from unskilled labor to essential workers overnight during the pandemic. Why? Because the President of the United States declared that meatpacking workers are essential workers by an executive order. So animal slaughtering and processing plants and industries are now the epicenter of some of the worst cases of COVID-19 outbreaks. And with that reason, 203 meat packers have died of COVID-19, and 42,234 have tested positive in 494 plants. So as you can see, occupational exposures played an important role in COVID Latino cases and their deaths. 34% of Hispanics are the workforce of the occupational exposure group. Most are young, healthy, and undocumented. Latinos live to work, and they work in jobs where the exposure and probability of dying is increased. They live paycheck to paycheck, face to face, interacting with everything that is dangerous in their jobs. The reality is that many essential workers keep our country economy running despite the vulnerability of the virus. So as you can see, Hispanics do not know how to file complaints regarding the illegal or the hazardous conditions under which they work. They have low bargaining power to advocate for safer work conditions. And OSHA, up to now, has received 8,000 complaints since April, but only 3 citations have been given in 1 state. And in addition, they have lower bargaining power for safer work conditions. They cannot publicize anything that is unsafe where they work because they are heavily dependent in keeping their jobs. So Hispanic workers less likely to exercise their right to complain, even though more exposed to hazardous conditions. That is extremely sad. So in the presence of all of these issues in the Hispanic community, the COVID-19 stimulus bill in March did not expand Medicaid eligibility to undocumented immigrants, excluding many of them from COVID-19 testing and treatment options, even as many put themselves at risk working in essential jobs. So you'll ask, what needs to happen? So according to Latino groups, they say Latinos are to be included in stimulus package and Small Business Administration disaster relief program. Congress must adopt a stimulus funding no less than 10% for every minority business that has gone down. There must be a moratorium of mortgage, of rent, of loans, and foreclosures without penalty. There must also be an OSHA protection for agricultural workers. There must be provision of health centers that are linguistically appropriate with programs that are not subject to eligibility restrictions. There must be temporary protective status for all immigrants that work on the healthcare during the pandemic, specifically the people from DACA. There must be a waiving or suspension of every copay with health insurance at lower cost coming our way. Let's remember, after all that has been said, that even when Blacks and Latinos share similar barriers, the same policy response may not be effective for all of us. So we have to start working in what needs to be done for all of us.
Hello, my name is Carlos Del Rio, and I'm a professor of medicine, epidemiology, and global health at Emory University in Atlanta, Georgia. And I'm here to speak to you about COVID-19. COVID-19 is a disease caused by a virus of the family coronaviruses. And coronaviruses are enveloped RNA viruses that are named like that because they have a solar-like corona appearance in surrounding these virions. And those that corona is made of a protein called spike protein, which is very important in attachment of the virus, but it's also very important in the development of vaccines that we'll hear about later. Coronaviruses are very common. 10 to 30% of common colds are caused by coronaviruses. They tend to replicate at lower temperatures, like the ones that exist in the upper respiratory tract, like in your nose. And these envelope helps them actually survive in places like the GI tract. And they tend to be fairly difficult to control. The coronavirus that we're talking about is called COVID-19, coronavirus infection, coronavirus disease of 2019. It was discovered in December of 2019 in Wuhan, China. And the natural host for many of the coronaviruses are bats. And because it's a new virus, there's a lot we still don't know. COVID-19 is caused by a virus that now has the name of SARS-CoV-2. And as you can see from this map, SARS-CoV-2 is part of the lineage B coronaviruses. It's very similar to the coronavirus that caused a disease called SARS. And in fact, SARS-CoV is that virus, and this one is called, therefore, SARS-CoV-2. And it uses the same receptor, the ACE2 receptor, to attach to cells. And this is important because a lot of the research that has been done on SARS when it was first discovered in 2003 until now was actually incredibly useful in developing a vaccine. And part of the reason why we have a vaccine so quickly is because of work done on SARS. So what is the issue with bats? Bats make roughly 20% of all the mammal species, and they live to reach 40 years or more. Their ability to fly means they can transmit viruses far and wide. And they have evolved to tolerate more viruses than any other mammals, and therefore are very important in multiple zoonotic diseases. Zoonotic diseases are diseases that infect both animals and humans. And part of this is because bats have suppressed their immune system, and that allows them to tolerate more viruses without getting sick. And this gives them an advantage. And there are more than 500 coronaviruses in China that come from bats. And therefore, China is a hotspot for bat-borne coronaviruses to emerge. There usually is an intermediate animal that passes in the virus to humans. You have heard sometimes the term Wuhan pneumonia, and that's because this disease was first described in the city of Wuhan, which is the capital of the Hubei province, which is in central China. In December 31st of 2019, the WHO China country office was informed of case of pneumonia of unknown etiology detected in Wuhan. And what's incredible is that by January 7th, the Chinese authorities had identified this virus as a probable cause. And the disease was then named by WHO as COVID-19, and the virus was named, as we mentioned already, SARS-CoV-2. The sequence of this virus, the genetic sequence, was rapidly posted online in multiple sites. And as a result of that, work on vaccines really began at that very moment. It didn't take long for work on vaccines to begin. We have learned a lot over the past year about these viruses, and the first thing we understand better is how they're transmitted. They're transmitted primarily through respiratory secretions, And this could be either through respiratory droplets or aerosols that either fly and stay in the air or that fall into surfaces. What we've learned is also that people can transmit it when they're asymptomatic or even before they develop symptoms, what we call the pre-symptomatic stage. And that makes it very hard to control because, you can be transmitting and feel totally fine. Stool is unlikely a source, and we don't think it's transmitted from the mother to the baby. So there's a lot of controversy about what is aerosols and what is droplets. And, in general, we think about droplets, something that is bigger, that they tend to be more than 5 micrometers in diameter. And therefore, you need to be, they fall quickly, they fall into the surfaces, and therefore, they travel less than a 6 feet distance. But there's also aerosols. Aerosols are smaller, and they can travel for a longer distance. And that's why, this social distancing of 6 feet, 6 feet is a good number, but it's not a perfect number. Even, if you are in a crowded room, 6 feet is not good enough for you to take off your mask and say, I'm totally safe here. The viruses can fall into surfaces, what we call fomites, and therefore that can be a source of contagion. And you can see here's an infected host and a susceptible host and how the transmission occurs. The other thing we've learned is that a lot of the transmission, a lot of the infections are caused by very few people. Roughly 70% of people who test positive don't infect anybody else, but about 60% of infections are caused by about 10% of people. And a lot of those infections occur in what we call super spreading events. And super spreading events occur in multiple places. They can occur in hospitals, in prisons, in nursing homes, in food processing plants, at churches, at sports events, at markets, and ships. So we know that the minority of people account for the bulk of transmission. That's something that helps us in trying to decide what to do and what kinds of activities are more dangerous than others. So where are we today? We're over 100 million infections worldwide and over 2.3 million deaths worldwide. And 50% of the deaths have occurred in the US, in Brazil, India, Mexico, and the UK. And in fact, the US, with 4% of the world population, is about 20% of the world deaths from COVID. The US has had over 28 million cases and close to 500,000 deaths. Then you can see there California has the most cases, followed by Texas, Florida, New York, and Illinois. India is number 2 in the world with over 10 million cases, and Brazil number 3, getting very close to 10 million. And then Russia, the UK, France, and Spain have over 3 million cases. So what is the map of COVID-19 in the US? Well, as you can see here in this epi curve, you can see that we had an initial peak early in March, and then we had a summer peak around July, August. And more recently, we have had what we call a fall peak, in which cases exceeded 200,000 per day. And now we're coming down from there, and most recently we are down to under 100,000 cases per day over several days, and that's a very good finding. But deaths are still pretty high, and in fact, we're still having about over 3,000 deaths per day, and that's still a very, very high number. Think about 3,000 people dying of this virus on a daily basis. If you want to get more updated information, I would recommend you look at this page that CDC just established called COVID Data Tracker. It's a really good page where a lot of this information related to coronavirus, including down to the county levels, is presented as aggregated and something very, very good to look at. So this most recent winter wave actually was incredibly significant because, as you can see here, almost half of the COVID deaths in the US occurred during this last November to January event. And in fact, in January alone, we had over 100,000 Americans that died of COVID. So clearly, when people say, well, this is not a serious disease, I remind them that this is a lot of dead people, and this is something that we need to take very, very seriously. The other thing that has happened with COVID in our country is that we've seen significant racial and ethnic disparities. As you can see in this iconographic from the CDC, African-American populations, Hispanic, Latinx populations, and American Indians and Alaskan Natives have been disproportionately impacted, representing about 2.5 to 2.8 more cases than the white population. Similarly, these populations have had a higher rate of hospitalization, sometimes up to 5 times higher, and also deaths. You can see, 1.5 to 2 times higher deaths in this population. So the disproportionate impact in minorities, this racial inequalities that we've seen, racial and ethnic inequalities that we've seen in this pandemic is something that many of us are very concerned about. How does this disease present clinically? Well, the incubation period is about 5 days, which means that, after you've been exposed to somebody, it takes about 5 days, on average, for you to get infected, to get sick, get infected. But it could be as short as 2 days or as long as 14 days. About 80% of the people have mild illness, primarily with fever, with cough, fatigue. A very interesting finding is a loss of smell and taste, which is very common. 30 to 40% of people have that. 30% of patients do get sicker and require hospitalization and intensive care unit and require also mechanical ventilation. What are the factors that determine somebody getting sicker? Well, clearly, the older you are, the more likely you are to get sicker, but also things like chronic obstructive lung disease, cardiac disease, diabetes, obesity, sickle cell, kidney disease, meaning immunocompromised and having cancer, all put you at higher risk of COVID-19 complications. Obesity is one of the major drivers of severe disease. And in fact, people that have a BMI, a body mass index, over 30 are higher risk of having what we call overweight, are higher risk of developing complications from COVID than those that have more normal body weight. Another population that is a significant risk of complications are pregnant women. And in fact, compared to non-pregnant women, pregnant women are more likely to be admitted to the ICU, to require mechanical ventilation, and to not do as well. So you can see here that when we think about this illness, it really is a full spectrum from asymptomatic disease to mild illness to more moderate illness, severe illness, and then critical illness. And really is a whole spectrum. And what we don't understand yet is exactly how to predict who's going to have just a mild illness versus who's going to be critically ill and even die from this illness. But we know that all these people require to be isolated. And the kind of treatments that we give depends on who you are. So early in disease, you may give antivirals like remdesivir, but later in disease, you are more likely to give anti-inflammatory drugs like dexamethasone, for example. One population that initially was significantly affected are healthcare providers, and transmission in hospitals was a problem. And you can see here that, when the CDC did this analysis, about 6% of all adults hospitalized with COVID were healthcare providers. And in particular, nurses were made about, 36% of that population. So again, this explains who is at high risk and what populations or what employments could put you at high risk of COVID. So what are the fundamentals to prevent COVID acquisition and transmitting of COVID? Well, universal wearing a mask, maintaining physical distance of at least 6 feet, avoiding crowds and congregate settings, thinking that things they do outdoors are better than indoors, and frequent hand washing are the recommendations. Masks are really important because if an infected individual sneezes or coughs and you have a mask, you get certain protection. But if both of you, the person infected and you, are wearing a mask, you get the maximum protection. So it's really important that you think about that wearing a mask is not only about protecting yourself, but it's actually about protecting others, because you can be asymptomatically transmitting and not know it. Social distance is also very powerful. You can see here that if you're able to infect less individuals down the line, you infect even less people. So one infected person in this disease typically infects about 2.5 people after 5 days. Those 2.5 people at the end of 30 days lead to about 506 people infected. So one infected individual leads to about 406 people infected. But if you're able to decrease that by 75%, so one infected person now infects less than one other person. And that means at the end of 30 days, you only have 2.5 people infected. So clearly, decreasing exposure is a very important way to decreasing transmission. And again, there are multiple behaviors that are low, medium, or high risk, and depending where you are. So, for example, if you are singing, if you're shouting, you're more likely to produce particles and therefore more likely to transmit to others. You decrease that risk by wearing a mask, but you increase it significantly by not wearing a mask. So again, you could be in a busy location, and you can be, with a poor ventilation, and that's pretty significant. There's a lot of risk no matter what you do, even if you're wearing a mask. But if you're not wearing a mask, your risk increases even if the location is outside and not in well ventilated. A lot of restrictions have been put in place for COVID, and what we've learned over the last year is that we need a clear face-up plan for moving to different levels of control. We also have learned that countries should not ease restrictions until there's a robust system in place to monitor the infection situation. And right now, for example, in our country, I'm very concerned that many states are lifting restrictions when we still have a significant problem. There's also very important that we are going to need continued measures to decrease transmission over time, such as face masks and decrease social interaction. And each country should have an effective test, trace, and isolate system in place. And we need to continue to invest in public health as an important strategy. Asia, for example, has done a good job in general controlling the outbreak. And that's because in Asia, you have a lot more extensive use of facial coverings, and you have a more robust public health infrastructure, and populations that are more compliant are more likely to follow the guidance issued by the government. And we need to, unfortunately, recognize that removing COVID-19 restrictions should be a cautious return to a normal, and we're not going to likely be back to a pre-COVID state anytime soon. Now, COVID is not just this acute infection that you either die or recover from. We've learned over time that people with symptoms severe enough to put them in the hospital frequently face a long road to recovery. And in fact, in the study from the CDC last July, we learned that not only people that end up in the hospital, but almost anybody with COVID, these are young individuals, healthy, at the end of more than 3 weeks, 1 in 5, we're still not feeling well. We're having fatigue, we're tired. So again, COVID can lead to this lingering symptoms over time. That is something that many of us are puzzled by. And finally, I want to mention that we're not just fighting an epidemic, we're really fighting what I call an infodemic. And the director of WHO, Dr. Tedros, has said that. And we know that misinformation in social media is not a new problem, but during this pandemic, misinformation has contributed to the deaths of thousands, and combating misinformation almost seems insurmountable, because fake news and social media have actually fueled the pandemic. And sometimes it feels like coronavirus fake news is spreading much faster than the virus itself. So with that, I'll end, and delighted to be with you. And again, please ask questions. And this is a time that everybody needs to be informed. Information is critical in the control of a pandemic. Thank you very much.
I'd like to express my thanks to the United States Hispanic Leadership Institute for giving me this opportunity to talk with you about vaccines. The best hope we have for controlling the COVID-19 pandemic is a vaccine. Vaccines against the COVID have two main objectives. One is to protect vulnerable people from infection or from disease. And the second objective is to protect societies, communities, by interrupting the chain of transmission of the virus and eventually allowing us to return to a more normal life. In general, vaccines simulate the protective immune responses that are induced when a person recovers from an infection or a disease, and that immune response prevents that people from getting infected again, from being reinfected. In the case of the COVID-19, we know that the protective immune responses are mainly antibodies that are directed against a protein which is present in the surface of the virus. It's the spike protein, we also call it the S protein. During the last year, many laboratories around the world explored different methodologies to present the S protein to the immune system to stimulate the production of neutralizing antibodies. Some of these vaccines were produced using methodologies that have been used for many years, while others use relatively new methodologies, but all are based on solid science. Once the candidate vaccines are developed in the laboratory using different technologies, they are tested first in animals and then in human trials. Phase 1 and Phase 2 human trials are to obtain information about the safety of the vaccine in a small number of human volunteers, normally less than 100, and they are conducted to confirm that the vaccines induce immune responses that we believe confer protection against the virus. And the next step is that the vaccines are tested in Phase 3 trials, enrolling thousands of volunteers, in the order of 30,000 to 40,000 volunteers. And that's how we obtain information about the safety of the vaccines and their protective efficacy. At that point, the vaccines are authorized for use in the United States by the Food and Drug Administration, by the FDA. After we obtain the results of the Phase 3 trials, now we know that the authorized vaccines against COVID-19 are very effective. In general, more than 90% effective in protecting against disease. And they are generally safe, only inducing minor discomfort on the site of the injection and perhaps some fever and malaise for 1 or 2 days. There are 2 highly effective vaccines that have been authorized and are now being used in the United States. One is produced by a company named Moderna, and the other by Pfizer-BioNTech. Both vaccines were manufactured using the so-called messenger RNA technology that takes advantage of modern science to develop a safe and highly effective vaccine. More than 80 million doses of different COVID vaccines have already been administered in the world, close to 25 million in the United States. And the plan in this country is to vaccinate between 100 and 200 million people in the next 3 months. For this, we have to acquire to purchase many more doses of vaccine, and it is likely that in the next few weeks, additional vaccines from other manufacturers will also be authorized. The challenge now is to provide 2 doses of the vaccines to 60 to 70% of the American population in order to interrupt the change of transmission of the virus. It's very interesting that early data from Israel suggests that with that level of vaccination, we can start breaking the back of the epidemic and seeing a dramatic decrease in the number of new infections. Now, I want to address 2 important points: potential safety concerns and the concerns related about the new viral mutants. First, there are many fake news circulating in the social media about presumptive side effects, such as that the vaccine can cause the disease, or that the vaccine induces genetic changes in the DNA, or that the vaccine causes sterility. All those accusations are false, but nevertheless, they induce fear in the population who may decide not to receive the vaccine. That unfortunate decision based on misinformation could have very negative consequences for the individual, for his or her relatives, and for the society in general. Now, the final point I want to discuss is about the significance of the recently announced mutants or variants of the virus. Now, it is normal for a virus to mutate. That's normal. Mutation is minor changes in the genetic structure of the virus. Most of those changes do not have any practical consequence. However, during the last few months have emerged new strains, especially from Great Britain, that are already present here in the United States. Those strains are more easily transmitted from human to human, and probably they are more pathogenic. But we know that they are blocked by existing vaccines, which is another reason to be vaccinated now. But other, perhaps more worrisome strains have arisen in South Africa and in Brazil. And those strains have the potential to escape the immune protection induced by current vaccines. With the information we have, we believe that the existing vaccines will still be protective against those strains, although perhaps with lower efficacy. Nevertheless, vaccine manufacturers are already developing booster vaccines to increase the breadth of protection of those existing vaccines. They will come in the future. We are experiencing the worst global public health emergency of the last 100 years. We are fortunate, however, that we live in an age of scientific progress that is providing us with the vaccines and other interventions to overcome this challenge. Each one of us has the responsibility to provide the leadership needed to help our communities during this difficult time. Many thanks for your attention.
I would like to welcome you to this session, which will be dealing with the topic of treatment or management of COVID-19, which I think is a very exciting topic right at this point, because there are some new developments that I would like to discuss. But before we go on...
Perdón, doctor.
Yes. Sorry
to interrupt. Can you tilt the screen just a little bit more? Because I realize I can't see your eyes at all. The glare.
Is that better?
I think we may need to reposition you. Can you, right there. Yeah, because now I can see your eyes, but when you lean, can you lean forward just a little bit? You see right there? I don't get the glare off of your computer screen and I can see your eyes. It looks, okay. It looks a little washed out. I am so sorry. We'll start again.
Okay.
All right. And 3, 2, 1.
Welcome to this session on COVID-19. We will be talking for the next 10 minutes or so about the management of this disorder, which I think is a very interesting topic because of the new developments that are taking place at this point. But before we go on to treat or to manage the patient, we first need to understand exactly how this disease evolves. This is a triphasic disorder. That means that it has 3 phases. The first one is the viral phase, in which the virus enters our body and starts replicating. This is known as the incubation period. And during this viral phase, which is also known as the first phase of the disease, when there's enough of the virus in our system, the patient will start developing symptoms. And the most common are cough, fever, general malaise, muscle pain, headaches, diarrhea, and shortness of breath. Those are the most common symptoms that they have to be aware of. This viral phase usually lasts from 7 to 10 days after the onset of the first symptom. And this is a very important point to keep in mind, as you will see later on. During this phase, it is important that we avoid using any treatments that can suppress the immune system, such as cortisone, because that will interfere with the clearance of the virus from our system, which could make things much worse. In other words, if you suppress the immune system, then the immune system cannot fight the virus, and it can actually make things worse if you use immunosuppressive therapy during that first phase. At the end of the viral phase, 80% of the patients recover without any further complications. We have learned in a clinical study that we just completed in my institution here in Puerto Rico that most of the patients, or the 80% of the patients who recover spontaneously, can be identified easily by ordering a set of blood markers. These markers are inflammatory markers that include CRP, LDH, ferritin, D-dimers, and interleukin-6. If 2 or more of these are elevated over a certain level, then most likely the patient will not do well and they will go on to develop complications. But if the markers are within the normal range or within the range that we have decided is acceptable, then those patients have never gone on to develop complications. Actually, we have a preprint of a paper that we just completed regarding what I'm just saying, because it's important not only to know how to treat the patients, but also to identify which are the patients that do not need treatment. So it's a very important aspect. The 20% of patients that fail to recover spontaneously after the viral phase, those are the ones that obviously will go on to develop complications because they will move on to the second phase, also known as the inflammatory phase. This is characterized eventually by development of pulmonary changes consisting of pneumonia, and shortness of breath will start occurring at this point and will get worse. And in approximately 5% of all patients diagnosed with COVID-19 will eventually move on to a third phase that is known as the hyperinflammatory phase, or the so-called cytokine storm. This cytokine storm causes what we call adult respiratory distress syndrome, also known as ARDS, and that will be the cause of death of most patients who die of this disorder. Actually, the vast majority of patients do not die from COVID-19. So that's something important to keep in mind. But the ones who do usually die from this cytokine storm. The treatment of COVID-19 depends on which phase of the disease it is diagnosed. If we diagnose it early during the viral phase, then there are two treatments that are helpful. The most effective one during this viral phase are the monoclonal antibodies known as bamlanivimab. Also, some people just refer to it as BAM because it's a tongue twister, as you heard already. But there's also a cocktail of antibodies known as casirivimab and indemivab, which are also very effective. Now, why are these antibodies so effective? It's because they are actually directed against the S protein of the virus, which is a key protein that is responsible for allowing the virus to enter our cells. They will block, the antibodies will block the capacity of the virus to penetrate our body and infect us. So they're extremely useful, but they have to be used early during the viral phase. They are extremely effective because they prevent the patients from moving on to the second phase of the disease, and thus they can avoid many hospitalizations as well as visits to the emergency room. It can also save lives. All three antibodies are available free of charge since the government, the US government, has bought them and supplied them to all USA states and territories. Paradoxically, these antibodies have not been used optimally, with only 10 to 15% of the stock available having been used. And they have been available now for a couple of months. It's difficult to understand why they have not been used more, but I think it's part of a problem that the patients cannot be admitted to the hospital because they're not allowed to be used in the hospital according to the approval from FDA. So most people who have to treat these patients in their office, and there are very few offices that have infusion centers. And in addition to that, you don't want to expose other persons who are not infected to those who are infected. So it's like a catch-22 situation. But there are some health, some infusion centers that are available, and there are also some health agencies that will deliver the treatment at the patient's home, which is the ideal thing, because we don't want them in the hospital. We want to have them with their family. We don't want them to be separated from their family, because that's one of the most traumatic experiences for these patients, to have to disassociate themselves from their families. Then there's another medication that also can be used during this viral phase. It's called remdesivir. Remdesivir is an antiviral agent which has some favorable effects against the virus, but it is not as effective as the monoclonal antibodies. It is important to point out that these medications, like I said before, if they're going to be used, should only be used in patients who are diagnosed within the first 7 to 10 days from the first onset of symptoms, what we call the viral phase. And they cannot be sick enough to require admission to the hospital. Okay, now if the patient is diagnosed right at the end of the viral phase and just before the second phase starts, that means 7 to 10 days after the first onset of symptoms. You know, the viral phase, like I said before, is during the first 7 to 10 days of symptoms. But if you're diagnosed right at the 7th to 10th day after the first symptom, then you're right in the interface between the first or viral phase and the second or inflammatory phase. We have found that these patients who are diagnosed right at that borderline between the first and the second phase, they can be divided into two groups. Those who are very likely to move on to the second phase versus those who will recover spontaneously. This separation of these two groups of patients can be done, as I already mentioned earlier, by checking some specific blood markers of inflammation. Now, if the patient meets criteria for treatment because they have the markers of inflammation that are associated with an unfavorable outcome, then we have found in a study that we just completed that methylprednisolone, which is a type of cortisone, can be extremely helpful in preventing those high-risk patients from progressing through the second phase. This medication should be given at moderately high doses intravenously in order to work. As you probably know, cortisone is an immunosuppressive agent. It's an anti-inflammatory, and that's why it works so well in these cases, because the second and third phase of the disease are associated with the severe inflammation and also with pneumonia. So if you can give these patients some agent that is a potent anti-inflammatory, then it can help prevent the complications that actually end up killing these patients. And like I said before, it can be given at the patient's home. Just like the monoclonal antibodies, we can also give methylprednisolone at the patient's home, thus preventing them from being isolated and separated from their close relatives. If the patient is diagnosed already after having entered the second phase of the disease, and the patient is oxygen dependent, then cortisone again is a treatment of choice. Because again, this oxygen dependence and these respiratory complications are due to inflammation, to severe inflammation. So a potent anti-inflammatory agent is necessary. The treatment of choice right now is dexamethasone, which is another type of cortisone, given at low doses for 10 days, has been actually associated with an improvement in survival in this group of patients. However, in our experience, we prefer to use, again, methylprednisolone instead of dexamethasone, not necessarily because methylprednisolone is more effective than dexamethasone, but actually because we use it at a higher dose than the dose of dexamethasone that is currently being used. So we use a higher dose because then we can prevent the inflammation better. And instead of giving it for 10 days like dexamethasone is given, we give it for a shorter length of time. We only give it for 5 days and then the treatment is over. It's been extremely effective in that setting. Now, if the patient presents already in a full cytokine storm, then those patients are in big trouble. They are not only oxygen dependent, but they are getting close to being will die. So we try to prevent them from progressing on to that phase. However, some patients actually present already in an advanced stage because they stay at home rather than seeking help early. So that's an important point. The patients should not stay home hoping that they will get better on their own. They should seek medical help as soon as they suspect they might have COVID-19. So the patient already presents during the cytokine storm. There's a study from the Netherlands showing that using high-dose methylprednisolone in combination with another agent that is known as tocilizumab, which is a potent blocker of an inflammatory molecule that is known as interleukin-6 or IL-6. That combination has been very effective in that study. However, not everyone believes that that is the right way to go. So there's still some controversy regarding the management of the cytokine storm. Before I close, I would like to mention that you should try to stay away from one drug that is known as hydroxychloroquine because it was supposed to be effective, but it's been shown in other studies that it's not only not effective, but also can have some serious toxicities and can increase the death rate rather than the opposite. Other medications that have been used for the management of COVID-19 are vitamin D, which appears to have some effect in preventing or improving the outcome of COVID-19. There's one study, randomized study from Spain, which showed that it does decrease the number of admissions to the intensive care unit. And other drugs that have been used, not drugs, but medications, are vitamin C. The data on vitamin C is not as strong as for vitamin D, but there's some indication that it might actually be helpful, but if given, it has to be given intravenously at mega doses, like 24 grams daily. So it's really not a very convenient medication to be used because you have to give it twice a day by vein, intravenously. Zinc has also been given by mouth, and there's some indication that it might help, although certainly the amount of information that we have regarding zinc and vitamin C is not as convincing as the information we have about the cortisone, like I said, methylprednisolone and dexamethasone, as well as the monoclonal antibodies. So this actually gives you a breakdown of how I manage these patients. Not everyone will agree 100% with our approach, but I'm fully convinced that it is effective. In fact, I'm finishing the manuscript summarizing our experience with the use of methylprednisolone for patients who are right in the verge of the first and second phase. And the results are really incredibly positive and very encouraging. So I hope that by next week I will have a preprint ready so that our results will be better known outside of Puerto Rico. Thank you for your attention.